I have no conflicts related to this presentation. By now, I'm going to go ahead and jump into the case because I figured right now plenty of data would have been presented. This is a case that was shared to us by our surgical colleagues at Duke. We have a 60-year-old construction worker with diabetes, hypertension, hyperlipidemia presenting with pain in the right lower extremity. His claudication is beginning after ambulating 15 feet. His right leg aches and tingles while sleeping. It's been waking up at night. All these symptoms escalated quickly over the last 2 months. We talked about his past medical history. Family history, both parents had lung cancer. This prompted him to quit smoking 25 years ago. As far as medications, you can see aspirin. He's on a few antihypertensives, metoprolol and rosuvastatin. No known drug allergies. Physical exam, he's still hypertensive, as you can see, even though he's on 3 medications. Cardiac was unremarkable. Pulses, femoral with 2+. Pedal pulses in the right were unpalpable, not palpable. Left foot were 1+. So appropriately, you got some studies, which you could see, right pedal, monophasic for both pulses, biphasic on the left. Let's take a look at his ABIs. You could see that the right are grossly abnormal. For some reason, he's still got an exercise study. So you can see at rest on the right was 0.6, dropped to 0.3. On the left was 0.9, goes down to 0.8. Labs were okay. So let's just go ahead and get into the conversation. What you can see here is we have a abdominal angiogram below the renals. You can see that the distal aorta looks pretty good. So do both iliac systems and the common femorals. Take a look at the right. You see a nice profunda. And you can see very slowly trickling in is the SFA. That's what my son looks like when I ask him to take out the trash. It goes that slow. Let's take a better picture. You can see on the top right, you can see the occlusion right there. I don't know why I went back. You can see the pop. Looks pretty good. Just for completeness, here's below the knee, 3-vessel runoff. Again, very slow. And for completion, here's what the foot looks like. He had no wounds or ulcers on his foot. So our colleagues attempted a endovascular. It was a standard approach. They used a 6 French Ansel, went up and over. And I believe they used a V18 and a support catheter. Never really escalated. You can see where they start. You can see the occlusion is not that long. Sure. Calcified. I would say this is probably less than 20.
Maybe 6 functional.
And they got pretty close. This is one of those that it gets so close it hurts.
Yeah.
See right there. Let it run one more time. All with a V18 wire, all with a support catheter. So at this point, they abandoned the integrated approach. They took the patient to surgery for bypass above the knee. It's July, so the vessel was damaged.
No.
So we got a bypass below the knee. So, you've heard plenty of data. I have some data slides after this, but this would be a good point for discussion, endovascular treatment versus bypass. Personally, I'll give you my opinion. I would have probably been a little more aggressive above, escalated wires. Worst case scenario, you can stop, bring them back from above. In that case, depending how long the patient would have been on the table, I would have tried a retrograde approach. We had 3-vessel runoff. The lesion looked very favorable from a retrograde approach. This is a case that I probably would use the crosser. Very easy to use, usually stays within the lumen. Obviously, the goal here for me would have been to try to stay within the vessel the entire time. As you guys saw, it was calcified. Maybe use some atherectomy there. But in light, hindsight is always 20/20. This would be a good time to maybe ask the panel, see if they would have, what are their thoughts?
Well, yeah, definitely. I think the intended primary modality of therapy is disabling claudication, probably the average risk patient or normal risk patient. The lesion anatomy pattern-wise is a positive lesion for endovascular therapy. So I think from that perspective, all the dots that he is are good. I agree that the technical failure can happen, although the prediction of a technical failure in this particular disease is very low, and I would agree with you, I would have attempted more.
And I have a question. Yeah, I mean, one of the challenges, we all work nowadays in systems, or at least a lot of us do. And I always find it challenging when you have a lot of variability in regards to skills, both on the surgical and endovascular side. I can tell you that, if I'm referring for surgical operation, whether it is cardiac or vascular, I select according to skills. I don't think all of the surgeons in my institutions are the same skill sets. Some of them much earlier in their career, some of them are older and have much more experience, some of them are experts in particular area versus others, and the same thing with endo. So how can we, in these situations where even the guidelines, even the surgical guidelines recommend that endo should work,
Yep.
and you give it a try and it's not successful, how do we make sure that this doesn't go to surgery, but rather goes to someone that maybe has a little bit more experience and can potentially treat this patient endovascularly? I don't have the answer, but I just wanted to open it up for discussion maybe.
So I can tell you what we've done. And so this case was actually done in the hybrid OR. It's different because now vascular surgery also has time about 3 days a week in the cath lab.
Right.
So it's usually there's an interventional cardiologist across from them, and it's easy to say, hey, what would you do next? Right. As opposed of, I don't have a surgical option myself. I don't cut people open. So I probably would have spent more time say, hey, keep on at it. But that's one way that we've, go ahead.
So I guess my issue is, you're portraying a complication or an ability to cross endovascularly, but these are the same people who damage the artery. What does that even mean, to damage the above knee popliteal artery because it's July? The point of the matter is you have to have trained individuals, both surgeons and endovascular specialists, to do what they're supposed to do.
Yep.
And it shouldn't matter whether it's July or not, because it's not the intern who is operating, right? So in this particular situation, you're presenting an example of an individual who is not skilled either in endo or open surgery.
I would urge the panelists, please take any random to use it as a template case, because there are specifics that we can argue upon. So, Michael?
I will say, at Ohio Health, we have a vascular institute. We have all specialists that deal with vascular, and we're kind of agnostic about this. We have a certain threshold of success we expect for people who do CTO work. And it doesn't mean you have to do CTOs, but if you're going to attempt that, we expect that you get there. And if you can't get there, then everyone's humble. We train you up, and we're very kind of team oriented. Whether you're a surgeon, an IR, an IC, so that's how, to answer your question, Maddie, how we deal with it as a system, so that we kind of bring everyone up. And if you don't have the experience, then you come scrub with someone, and we do these cases over and over until you do, and then you go on.
So we started doing a combined endovascular and vascular surgery meetings. Initially started once a month. So we have once a week endovascular meeting for the cardiology fellows and interventional cardiology fellows, and we merged it with the vascular surgery fellows. And we started learning from each other so much. They started sending us patients when they thought that, they could not wire, but we will be able to wire, and they will send it to us. And vice versa, we send those patients where there was a true hybrid approach needed to them, and it really has worked really well over the last 8 years now.
Great. Zioi?
I think for us, it's, more individually, I think asking for help is not a weakness. I think you have to. For me, I'm relatively young in my career, and I have just last week asked one of my partners because I could not get across a lesion. I've tried all the things I know. Let's bring him in and see if he knows anything to help me. And I feel like if you're going to be a good technician, either in surgery or endovascular therapy, you got to be open to asking for more opinions.
Great. Art, you have a comment on this case, please?
We have two vascular surgeons in our group, so we have meetings and we look at films, and we have that conversation actually below the knee amongst my cardiology partners. This case is a little weird. That's breast pain for that anatomy. I thought there was gonna be clot in that. I thought the SFA was just not occluded. I thought it was clot, and I wonder if it was just a wire dissection, and but just weird to have breast pain with that just SFA occlusion.
I think this is a great case, and any simple case can open up a Pandora box of questions. But another perspective I just want to throw out, you may agree or disagree, that in a patient like this, if it were a claudican, for example, there is no harm in stopping and coming back. I think that's one. The second thing I noticed in the angiogram, which is very good and interesting, and you have seen it all in CTOs, that the distal popliteal or the proximal popliteal artery fills first very rapidly, and then it fills slowly higher above. And I call it the secondary filling. And pathologists have shown that sometimes the area of secondary filling is actually filling through microchannels and not a continuous column of true lumen. And if you ever try to re-enter in that segment, you can have significant difficulty. So there are some cute aspects to this case, and I appreciate, Tony, you bringing this very straightforward in a sense, but at the same time, quite complex in approach case to us for discussion. Stay here for a minute. I think Christian has a comment.
Yeah, one more technical aspect when you're for the vascular surgeons in the room is when you do have a failure and a technical, immediate technical failure, unless you have an immediate technical failure that leads to acute limb ischemia, you don't have to rescue that right then and there just because you have the hybrid room, because the wires may have penetrated the subintimal, the artery may be damaged, your target artery may be conditioned. That will heal, and you will probably not, relinquish a target artery for later bypass.
Thank you very much. We're going to end the session, but hold on. We have had 2 peripheral sessions, and there is one question that has been asked multiple times of me. I'm just going to ask this very contentious question to our panelists, starting from my extreme left. Tony, have a seat. As very quickly, Zioni, in claudicants versus CLI, when do you absolutely do or absolutely don't use pedal or retrograde approach? Yes, no? And please state your positions. This is a question that I've been asked multiple times. Do you do retrograde approach in claudicants, especially pedal?